10. You are live.
Good afternoon and welcome back. I'm Cindy Barassi, the president of the Colon Cancer Foundation, and I am so very pleased to be with you this afternoon for a special breakout session called Integrating Music Therapy and Cancer. And I have with me this afternoon Dr. Joanne Lowy. She is the director of the Department of Music Therapy. She's also an assistant professor at Icahn School of Medicine at Mount Sinai. She's a founding member of the International Association for Music and Medicine and the Department of Music Therapy, which she initiated in 1994. I'm also joined by Dr. Andrew Rossetti. He's a senior clinician, international lecturer, and a featured researcher and educator, and the supervisor of the Louis Armstrong Center for Music and Medicine, which is a multi-site music therapy program in radiation oncology within the Mount Sinai healthcare system. I don't often admit this, but I've been playing piano for many, many years, so I'm especially intrigued by this program, and I've been wanting to bring this to the Early Age Onset Colorectal Cancer Summit for many years. So please join me in welcoming both of them to the summit stage this year. Again, Dr. Rossetti and Dr. Lowy, welcome.
Thank you. We're so excited to share a bit of our research and clinical activity.
Yeah, thank you, Cindy. We are thrilled to be here and looking forward to being able to address any questions that might come up about the program or any of our praxis.
Wonderful. So we actually have their presentations pre-taped, so we're going to roll those now, and then we'll rejoin you after those presentations for live Q&A and back and forth discussion. So we'll see you in just a little bit. Abby, go ahead and roll the tapes.
Hi, my name is Dr. Joanne Lowy. I am sitting here in the Louis Armstrong Center for Music and Medicine at Mount Sinai Union Square downtown. I've had the privilege and good fortune to be the director of the Louis Armstrong Center for 27 years. In the last decade of our expansion and growth, we noticed that cancer, and most particularly the fragile areas of cancer, are areas in hospitalized clinics and music and medicine that perhaps could bring the most fortitude for patients undergoing cancer treatment. I've had the privilege to work with Andrew Rossetti. I've had the privilege of working with Dr. Manjit Chadha. We established roots of this critical area that's quite underserved, called radiation therapy. Early music therapy studies and clinical work focused on patients who were hospitalized for their cancer. What we've learned in the growth of music and medicine, in the growth of music therapy, is that patients undergoing radiation and chemotherapy experience symptoms that could be profound. Then we piloted research, which you'll hear Andrew Rossetti talk about, along with Dr. Chadha and doctors and nurses. Everyone put in their perspective on how the treatment of cancer and the trauma of being diagnosed with cancer right at the get-go, right at the first treatment, could change how patients perceive their illness. We're proud today to be part of colon cancer and all the work that Cindy and her colleagues have pulled together. We feel this following presentation will present a unique perspective that may hold patients through medical aspects of treatment. We are looking at medical aspects of treatment, such as how patients breathe, how they think about their cancer, how they perceive what will happen in radiation. As part of that assessment, we bring in culture. What kind of music can they bring to hold them through this difficult process of cancer treatment? I'm thrilled today that we've been invited by the whole team to be part of one of the ending presentations. And we hope coming out of this that all of you that are watching this presentation may access our team in helping to build music therapy, music medicine models in cancer treatment, and most particularly in the fragile areas of cancer, of which radiation therapy is one. Thank you.
I am Dr. Manjeet Chadha. Thank you for the opportunity to speak about music therapy and emerging fields of integrative medicine that helps patients' symptom burden. Nearly 2/3 of all patients diagnosed with cancer will be treated with radiation at some point during the course of their disease. During treatment, patients experience variable degree of emotional distress and anxiety that is overwhelming. Actively managing the patient's anxiety through treatment with the intervention of music therapy helps patients to better cope with their physical strain and stress. For instance, I remember a 9/11 survivor whose cancer treatment required radiation. To manage her extreme level of distress, we successfully used music therapy to help her through her treatments. She was so grateful to have this measure of support to help her cope through her anxiety. Encouraged by this and other observations, we conducted a randomized trial studying the impact of music therapy on patient distress and anxiety during a special type of radiation procedure called simulation. In all patients, we measured anxiety and distress before and after the special procedure using the validated STI-S anxiety questionnaire and the widely accepted symptom distress thermometer. During the procedure itself, half of the patients received self-selected music therapy and the other half did not. Results showed statistically significant drop in both the anxiety scores and the distress scores among patients receiving music therapy. The integrative approach of music therapy has great appeal because this intervention is culturally centered and can be uniquely tailored to the patient's individual preference. Emerging data similar to our research and having dedicated sessions at oncologic conferences like this one will help grow the knowledge and advance the field of music therapy in medicine to ultimately benefit our patients. Thank you.
Hi, my name is Andrew Rossetti, and I'm a board-certified music therapist and licensed psychotherapist in New York State. I work in the Louis Armstrong Center for Music and Medicine at Mount Sinai Healthcare System, and specifically I'm the supervisor for the music psychotherapy program in radiation oncology here at Mount Sinai. I've had the good fortune to work with Dr. Chadha and Dr. Lowy for about 10 years at this point, when I was hired to help start this budding program in radiation oncology. And we're quite proud of this program. It was the first of its kind, and based on something that we feel is very important, which is this idea of continuity of care. Continuity of care is a paradigm by which we try and follow patients throughout their entire trajectory, through each of their treatment paradigms, their treatment modalities for cancer, and that includes chemotherapy, radiation, and also surgery. So as I said, the program started about 10 years ago. And as we were designing the program, looking for how this could be the most effective use of music therapy in this context, we decided that the best thing to do was to observe as many patients, interview as many patients, interview as many doctors and nurses, technical staff as we could, to try and identify what may be the most salient issues that patients would be facing during their treatment. And that led us to find some very specific things that occurred that we thought were quite important, that occurred during the patient's very first encounter with radiation therapy, which was this process called simulation. And it was very interesting because many patients identified simulation as being one of the most stress-producing moments of their entire treatment trajectory, which we thought was quite a huge statement. And so we decided to look very carefully at this process of simulation and try and identify what the most important difficulties were that patients would be facing. And we found three principal things, and decided to design a protocolized intervention towards those three goals, towards palliating those three problems. The problems that we found were that many patients had some degree, and many times significant, and at times clinically significant, anxiety and distress. We also found that they reported that the procedure itself was physically uncomfortable because of the treatment table not being able to have any padding that would any sort of lateral movement during the simulation procedure. And third, we found that it was actually quite common, the incidence of claustrophobic events, or at least claustrophobic ideation during the simulation process. So we designed our protocolized intervention around those three goals. I'm going to be showing you what that intervention looks like in a few minutes. So I'd like to provide an experiential for you, show you a snippet of what this protocolized music psychotherapy intervention would look like. As I said, it's designed to address three salient issues that patients face when they come in that first day for simulation. And it is based on an induction and using imagery and suggestion along with music. And I'll explain a little bit some of the more mechanistic parts of it once I've finished showing you the intervention itself. So we're going to do some role playing here, and I'm going to invite you to sit back, relax, get yourself as comfortable as you can in that chair, and just allow yourself to focus on the sound of the instrument, focus on the music. Let's start off with a deep breath, as deep as is comfortable. Exhale when you need to. When you're ready, let's try another big deep breath. Exhale when you need to. And when you're ready, maybe one more big deep breath this time. Long, slow exhale like you're breathing out through a straw. Long and slow, long and slow. Perfect. Allow yourself to focus on your breathing, on the physical sensations, what it feels like when you breathe in and breathe out.
Now, this isn't an exercise, so you don't have to try and breathe in any special way. Just breathe as you need to and observe. Allowing yourself to focus on your breathing, and as you do that, likely you'll begin to notice some subtle physical sensations related to your breathing, almost as if they were a series of events. And probably the first one you notice when you draw a breath is the sensation of air flowing into your lungs and your lungs expanding. Allow yourself to focus on that one natural, subtle, physical sensation, drawing breath, noticing air flowing in and flowing out. Allowing yourself to focus ever more deeply on your breathing, more and more focused, deeper and deeper. Totally aware of your breathing now. Here's the thing about focusing. We can do that for very short periods of time before other thoughts pop into our minds. You don't have to try and block those thoughts out. Just recognize them for what they are. Allow them to pass through. And then gently turn back inwards once again, allowing yourself to focus completely on the physical sensations of breathing. Let your focus shift now to the chair you're sitting on. Let yourself become aware of the chair, its surface, and notice how the surface of the chair supports you and bears your weight. Focusing on the chair and its surface, and allowing yourself to settle into that surface. Now, the idea of settling in often is accompanied by thoughts and images of floating or drifting, somehow descending. Aware of the chair and its surface, allowing yourself to settle in ever more deeply. And as you do that, you may begin to notice that the surface of the chair begins to feel a little different. It may begin to feel spongy, softer, or almost as if it's beginning to conform to the contours of your body. Focusing, settling in, deeper and deeper, drifting, floating, somehow descending. Allow your focus to shift once again, this time to your mind's eye, to your imagination. Think of a place where you feel safe and comfortable. It could be any place you wish. A place you've visited, a place you'd like to visit, or a place that exists only in your imagination. Thinking of a place where you feel safe and comfortable. And as you think of it, allow yourself to see it in your mind's eye. And as you see it, allow yourself to go there. In this place you've chosen to visit, look around and see what there is to see. If you're outdoors, that might be forests or fields, mountains, perhaps a seashore. Looking around, exploring, seeing what there is to see. And as you do, allow yourself to experience any physical sensations related to what you're seeing. In this place you've chosen to visit. slowly and gently begin to come back to the room, allowing yourself to be aware of the room, the lighting, feeling your feet firmly on the floor. And when you're ready, you can take a big deep breath and slowly and gently begin to open your eyes. How was that for you?
Excited to share now some slides of what actual music therapy looks like in radiation oncology. So, integrating music therapy in cancer care needs to be done carefully. And our team, which is comprised of medical staff and music therapists, have been doing this for 27 years. And what's different about the music therapy we provide is that it's not only inpatient. We focus on fragile areas. Chemotherapy and radiation are fragile areas where patients have things done to them and there can be symptoms. So we've studied this. And at the Louis Armstrong Center, we have lots of studies in lots of areas. It's important to know that we treat through the lifespan from NICU through end of life. We also have a clinic. At our clinic just upstairs from RadOnc, patients can continue coming, fragile patients. And we do a lot of grant funds, and we have a gala each year. The bigger picture of music and medicine is IAM. IAM is actually the International Association for Music and Medicine. Anyone can join who's in medical or music therapy or music and health related fields. So check it out. Basically, the Louis Armstrong theoretical orientation that you'll hear today is a live music psychotherapy model. That means not just playing music or recordings, but using music in a relationship. And we look at what helps patients tick. How do they already use music, perhaps, in their lives? We look at past trauma, especially medical trauma, and culture. Multicultural is a big part of our work. Some of the areas that have sprouted out that our research has critical involvement in is trauma, breathing, respiratory, especially with COVID, sedation, and sleep. And this is a picture of the operating room. We go right in and help ease of transition from wake to sleep. So look us up if you're interested, or you have people you know who might want to explore music therapy and medicine. We have a recent study in chemo and resilience. We have a recent study in the Journal of Asthma, COPD, spine, NICU, radiation oncology. And so I'm going to ask you to think about these areas in terms of not just getting people through RadOnc today, but these very important areas that can help people maintain control of their thoughts, of their spirits, and of their bodies. We're very proud today to present Dr. Andrew Rossetti, Dr. Manjit Chadha, who will talk about specifically music therapy in radiation oncology. I'm going to call up my colleague, Andrew Rossetti.
Good afternoon, thrilled to be here. I'd like to continue Dr. Lowy has spoken about in our program, going a little deeper into some of the theoretical background and some of the actual clinical work in radiation oncology. So as Dr. Lowy mentioned, our model is medical music psychotherapy, and we see that as a merging of mind-body treatment experience with allopathic medical practice. Question comes up, so what actually is music therapy? And music therapy can be seen as being an evidence-based systematic interventions that are carried out by a board-certified licensed music therapist. And that's where the therapist treats patients to promote health using musical experiences and, very importantly, the relationship between them and others integral to the treatment experience. And this differs from other areas of psychotherapy in that it employs the inherent properties of music and sound as a medium or moderator of the therapeutic relationship and uses the metaphoric and associative properties of music to facilitate change, which is what therapy is all about. So sometimes it's easier to look at things in images rather than words. So here's this idea. We don't literally, of course, combine Freud and Beethoven, but you get the idea. And so this is using psychology constructs and strategies, mostly oriented from psychodynamics and humanistic practice that's combined with music and its elements, once again, as medium and enabler in the therapeutic relationship or alliance. A little bit about the clinical properties of music. Music is by nature metaphoric. Metaphors elicit images and associations. So if we were to look at, briefly look at our thought process, we would see that we think in words and images. So if we connect the dots here, images can be created through music, and that would enhance the direction of a therapeutic process. Metaphors elicit images, we think in images. So isn't this really a direct via into one's psyche and soma? Another important clinical property of music is this idea of entrainment, which is a physiological phenomena that is characterized by sort of bidirectional calibration of diverse functions of the human organism with the elements of music, meaning rhythm, melodic contour, and this idea of anticipation and resolution. And also very importantly is that emotion regulation is the single most common use of music. There was a recent study carried out in the United States that showed that people between the ages of 20 and 50 spent an average of 2 hours a day using music for emotion regulation. So when we listen to music, there is a systems response, and that is based on responses in cognitive and executive function, also the emotional brain, the limbic system, the autonomic nervous system. There is vagal regulation of state that occurs when we use music in a therapeutic process, as well as responses to motor activation, calibration of heart rate, respiratory rate, and other internal rhythms. And that involves our centers of reward, motivation, and pleasure. It has to do with arousal versus hypometabolic states, and also focuses on social engagement, group cohesion, and experiences of spirituality, peak experience, and the sublime. So these are some of the specific areas that of intervention that we use in music psychotherapy in outpatient radiation oncology, and we address treatment burden in general. Specifically, we do a lot of focusing on the simulation procedure for radiation therapy. We also provide interventions in the radiation therapy treatment rooms themselves when that's necessary. Also in chemo infusion suites, we provide procedural support for stereotactic radiosurgery procedures, also procedural support for blood draws, venipunctures, and hydration. We also work with patients that have phobic reactions, have claustrophobic events during treatments. We provide something called environmental music therapy in oncology waiting areas as a strategy to sort of change perception of the environment itself. And we provide music psychotherapy both pre and post radiation. To continue with our areas of intervention, specifically not just treatment burden, but illness burden, we are looking to provide support for emotional disturbances. That often includes depressive states, post-traumatic stress disorder. Anxiety disorders are actually quite common. This idea of meaning making in palliative contexts. We also provide biopsychosocial pain management. We provide patients with resources for self-regulation, and we also help them with sleep disturbances. So our areas of intervention include working with emotional trauma, state anxiety, as I said, depression and mood disorders, patients' emotional needs, spiritual needs, especially in palliative care and end-of-life care. We are focused on enhancing quality of life, pain management through various strategies, cognitive, emotional, and release-oriented strategies. We help patients with the temporal distortion that occurs during treatment, work with them on getting through their feelings of loss, which often includes areas of physical loss, psychosocial or existential loss, as I said, procedural support, and dedicated interventions to pre-simulation. This is just a shot of an article that the program was featured in the New York Times recently. That is available online if you're curious to see what the article had. So one of the areas that we focus on a lot is this idea of simulation. And we actually have a protocolized intervention, a medical music psychotherapy intervention that looks to install resources, and we see it as being prophylaxis for medically induced trauma. Now, a little earlier in the talk, I provided you with an experiential where I was playing guitar and doing a verbal induction at the same time. And that's actually the protocolized intervention that we use, that patients receive before they go in for their simulation procedure in radiation therapy. And we think that this particular intervention, which was the object of a randomized control study here at Mount Sinai Beth Israel, we think that this is something that helps tolerate isolation and restraint, which are two very potent stressors that patients are subjected to during simulation. And through very careful analysis and interviewing patients, speaking with medical staff, we identified 3 factors that contribute to patients' difficulty in successfully completing simulation and relative comfort. And that experiential of the intervention, which I gave you, highlights those 3 areas. The 3 areas are, first of all, the ubiquitous state anxiety that patients experience their first day when they come in for simulation. So the first part of that induction has to do with a breathing-focused technique that is designed to lower state anxiety. The second factor that we found is the physical discomfort of having to lie very still on a sort of very hard and unyielding surface, the treatment table itself. So there is some suggestion as to how to focus on the surface that the patient is, in this case, would be sitting on or lying on, and how to use suggestion to make that surface feel more comfortable. And the third factor is that often it was fairly common for patients to have claustrophobic events during simulation due to restraint and isolation. And so the third part of the intervention is guided visualization that tries to take the patient to a place in their imaginations where they are actually outside of the treatment room itself. So as Dr. Lowy said, we are research-based practice. This is the IRB that I was talking about for the intervention for pre-simulation, which was published in the International Journal of Radiation Oncology, Biology, and Physics in 2017. And it just so happens that that article 2 years in a row was made the list of the 20 most downloaded articles in the Red Journal. And here's just some quick metrics on the study itself. We found very robust outcomes in reduction of distress and state anxiety, and found that not only was there statistical significance, but there was also clinical significance in the results. And now I would like to show you a video that was made to highlight the program of music psychotherapy in radiation oncology. And here I'll play that for you.
The diagnosis of cancer is a life-altering event.
You know, they're unsure. They're anxious about it. They feel like their life is going to change. So I referred patients to music therapy because I could see the anxiety.
When patients are receiving radiation therapy, there is a myriad of secondary problems and issues that can come up. And this is what the program in music therapy is directed at. So the first intervention that they have when they come in for treatment is actually music therapy.
Cancer's scary stuff. And then I show up for the initial marking meeting. I got to meet Andrew and talked about the music therapy program and their goal, the stress reduction and the comfort. And all of a sudden I could sense my stress level declining.
The first session is like the first time I felt some hope. I was still nervous, but I felt hope, and I felt that I might do it.
What we do here at the Louis Armstrong Center and what Andrew Rossetti and his team have been able to prove through their research is that aligning with the patient right when they're diagnosed, right when they come in and they have to go through simulation, can have better outcomes throughout the radiation process.
Some of the issues that patients face during simulation, if you can imagine what it might feel like to lie on a flat, hard surface for an extended period of time, if you add to that whatever physical ailments they have going on, it's very difficult. And I think emotionally, it's a bit of a strain for them as well. It's an unnatural place. Everything is new. Everything is unknown.
The first day I arrived, it was the simulation. I need to have a mask on my face, and then when they prepared the mask for me, I felt confident doing that. I thought I'm strong and I have no problem doing stuff like that. But when I was there, I started to feel panic and stress. And when I left, I was a bit terrified and didn't know that's what about to happen every day. It's a part of what it is that they need to go through. But then when they go ahead and do a simulation and they see how the music is a part of them, especially because the music is being individualized to them, that they feel we're helping them through this, not that they're another person who's just going to have a treatment done.
I've had patients that will absolutely not get on my table without the music. And a lot of them say, you know, I feel it in the core and it takes my mind where it needs to go.
The application of music therapy in medicine is a perfect example of personalized intervention, where the intervention is tailored to the individual needs of the patient.
So the music therapy program was instituted and brought into the oncology, specifically the radiation oncology department, and has been an integral part of patient comfort and putting them at ease virtually from the first day that they come in for the planning of their treatment, throughout the course of treatment, and even in the follow-up clinic. So the music therapy program has taken what is something that we all turn to at all parts of our life and has given patients a level of comfort, of distraction, of familiarity, an environment where none of those otherwise exist and are unfortunately not always provided.
This is where you have to go, because they deal with you as a whole person, not just a body with a dis-ease.
I cannot really say how important it was. It was just enormously important. It was the basic thing. This is the very basic help that he received, and for which he was really, really grateful. And we all were very grateful.
Music therapy goes beyond just music, of course. Music is great in and of itself, but music therapy can specifically get at what the patient needs therapeutically through music in a very profound way. And we would be very blessed to have this as part of our program here.
We're very proud of our 20 years of research, and we're most proud of this budding Gary Dial Fund, where doctors and nurses at other hospitals of Mount Sinai, Dr. Ron Ennis and his team, are taking what we've been able to pilot here and growing it in another hospital. Through the Gary Dial Fund, we'll be able to change the way people enter the world of cancer.
Hi, I'm Gary Dial, and I have the great honor of representing the Louis Armstrong Center for Music and Medicine for Radiation Oncology. Thank you so much.
So one of the things that I think is really important about this video is it highlights just how important it is to, this is an real interdisciplinary effort, and showcases how closely we work with medical and technical staff. So to continue, our approach is very much trauma informed, and we approach this by this idea of the 4 R's, the realization of the impact of trauma on the individual, recognition of signs and symptoms of trauma, response by integrating knowledge about trauma and its adverse consequences into policies, procedures, and practices, and we resist re-traumatization. It's also important to point out that not only are we trauma informed, but we also treat trauma and post-traumatic stress. I'd like to talk to you a little bit about our approach to emotional trauma. This is something that the focus on trauma is something that has changed dramatically in the past few years. There are some new definitions, and perspectives on emotional trauma itself. It is seen as an overwhelming life experience and has to do with psyche and soma in a hyper-aroused and paradoxically coexisting shutdown state. It is thought at this point to be both physiological, psychological, and biological in nature. It can be stored as a sense memory in the body, and it very much has to do with this idea of the body being reset to interpret the world as a dangerous place, the inability to feel safe. So how that works out in care is that the medical music psychotherapy interventions that we provide are exploration and expression of the individual's emotions when the memories of trauma and transgressive events are triggered. The music, importantly, can represent external phenomena. That's one of the actual characteristics of music that make it such an important clinical tool, is this idea of symbolic representation. Music is very much represents something other than itself. It is about shared transitional space that creates an avenue of treatment where the traumatization is exposed, and through music it can become less direct and ultimately less threatening. Individuals utilize the musical and non-musical representation to give voice to their conscious and unconscious thoughts and feelings, and capitalize on these opportunities to redefine the sense of self narrative. So music can create a real sense of continuity and community with interlocking experiences that are created through the ability to play and communicate simultaneously. Music stimulates the human auditory system, influences vagal function, and downregulates autonomic nervous system response to modulate what are referred to as non-functional states, such as fight or flight and shutdown, and create a sense of safety that is very, very important in treating emotional trauma. So we are moving in the right direction. The mental health care community's thoughts on the nature and treatment of trauma have experienced a whirlwind of change in the past 5 years. 20 years ago, trauma was a term that was almost exclusively connected with victims of violence and combat. It was defined in the DSM as an event that was outside of the range of normal human experience. That definition has changed radically, as has our approach to treatment. And this is about helping patients find safety in the felt sense of their bodies, to discover their resources, to foster resilience. And models have moved forward to include body-centered, sensate psychotherapy that works effectively on emotions and cognitive schemas rather than this idea of desensitization. So I would like to invite you to join the International Association for Music and Medicine. Dr. Lowy mentioned this really wonderful organization. We have a great journal, which is Journal of Music and Medicine. And these are some of the recent articles from the April 2020 edition. We have a conference coming up with John Batiste, who just actually won an Oscar for the movie Soul. And we invite you to follow us on our Facebook, Twitter, and other accounts. And we invite you to come and visit us for orientations and observations that we provide for medical staff. And now we'd like to move into a question and answer period.
Welcome back. That was incredible. Well, I had a few questions. Well, first, I just want to say I learned a great deal about what you're doing, and it's a little ironic because we just held a session earlier this morning titled "What are the key elements of coordinated care for early onset colorectal cancer?" And we thought we had all of the clinicians that should be considered key members of the interdisciplinary team to care for young patients during their journey through the continuum of care. But I think next year we need to add one or two of you into that panel. Dr. Rossetti, you specifically mentioned continuity of care, and here at the foundation, we specifically about the continuum of care, a patient's journey through the continuum of care, and how important it is for us to consider that journey. And we actually start way back, before we try to include the prevention of this disease from ever happening. And then we also go even beyond the patient to the caregiver. One of the questions I have for you is, how do you specifically work with the patient's treating physicians is the first question. And then the second question is, do you ever get involved with the patient's caregivers?
Yes, sure. Great questions. We work exclusively on referrals from medical technical staff, social work. So all of the interventions that we would have, for instance, if I were seeing a patient through their initial surgery following chemo and radiation, that would all be coordinated with their attendings for each one of those areas, with their surgeon and medical oncologist, radiation oncologist. And do we include caregivers? Absolutely. Absolutely. So there's this idea that I like to think of, which is called a nucleus of care, and that includes both professional and personal caregivers. So we do actually provide music psychotherapy, especially in radiation oncology, for family members of patients while they're getting treated. And we also try and address vicarious trauma in staff as well.
Okay, yeah, I could see that being especially important right now during COVID.
Absolutely.
Yeah. Well, one of the things that was specifically brought up during our panel this morning was the fact that, we're dealing especially with younger and younger patients. In fact, one of the most rapidly rising demographics is the age group 20 to 29-year-olds. So I don't know if you're actually seeing them in, your program, but what's common is that, these patients have young children of their own. So I don't know if you're seeing them in your program, if they're part of those families, if you could talk a little bit about that, if you're seeing that.
Sure. Just quickly, and I'll hand this off to Joanne to continue the answer. Yeah, I can't say that I've seen a huge uptick of that particular cohort in radiation oncology, but there is, of course, there are women in that age group that we do treat. Specifically, radiation oncology, I guess, is where I'm seeing more of it.
Dr. Lowy, would you care to comment on that?
It's interesting. A few years ago, we set up a focus group before a research project. And one of the interesting outcomes was, this addresses your first question, that patients wanted a differentiation between carers who were family members who love them and are part of their life, and professional caregivers. So we actually often will call
husbands, wives, children, carers now, and nurses, doctors, aides, caregivers. There's a distinction, but continuity of care has been something we've always strived to carefully practice, especially in our hospitals merge, where patients can go downtown, uptown, in hospital, out of hospital. And I think the most beautiful extension of continuity of care that Andrew has really moved along in our clinic that's quite exceptional is when people are done with treatment. I don't know if we're still saying cancer-free. I think that's usually a no-no. The wellness provided thereafter, not just for people who got through radon, but who now want to maintain their wellness. That continuity of care, that you don't just come for music psychotherapy because you had treatment. He actually keeps them for years beyond to maintain resilience. And I've marveled at that progress.
Mm-hmm. Do you care to comment on that, Dr. Rossetti, about I guess the continuity and how that may have progressed in our view of wellness? I'm hopeful that that's changing, and the concept of integrative care in general. And that was actually commented on the panel before. I'm sorry to keep referring to that, but we actually had a pediatric oncologist on the panel because we're seeing extremely young patients, 18, 17, 16. And so they get a diagnosis of colon or rectal cancer, and they're going to live hopefully 40, 50 years and be cancer free, or, no evidence of disease. So we hope that this concept of wellness, of course, lives with them. So
absolutely. I mean, there's in the video that we showed, there was a radiation oncologist, Dr. Daniel Shasha, who made, for me, it's just an incredible opening statement that the diagnosis of cancer is a life-altering event. And, that's very much the idea that we work with, as Dr. Lowy mentioned. It's fairly common for patients to continue post-treatment in our clinic because of the implications of that life-altering event. And often it's imperative to work with people on helping them develop resources, develop their resilience, and coping structures. How do I get on with the rest of my life? Right?
Mm-hmm. Well, on that note, I hate to say this, but we're literally out of time. So I hope that we can continue this conversation. The foundation is going to be hosting a series of fireside chats this year. So I really do hope that we can get back together at some point in the very near future. Very quickly, please, if you would just tell people how to reach you if they have any questions. Oh, you're on mute.
info@musicandmedicine.org. info@musicandmedicine.org. Cindy, thank you for this wonderful opportunity. Congratulations to a great conference.
Thank you. Thank you so much for being here.
Yeah, it's been a real pleasure. Thank you.
Thank you. Have a great afternoon.
You too. Bye-bye.